Hi, this is Brian Kim. I'm going to share with you case number 68 in the best way to do cataract surgery series. This is kind of an average lens density, and you'll see my typical technique for double chop and cross chop to disassemble the lens. You'll see the cortical flush technique that I use to remove stubborn subincisional cortex. So I use a cotton tip to steady the eye and center the eye, and I use a corneal marker which will help me to center and size my rhexis. As I'm holding the eye with a cotton tip, I make my paracentesis incision, first on the right side, and then now on the left side. I always use a cotton tip to steady the eye in case the patient suddenly moves. I want to make sure my paracentesis is flat to the iris plane, parallel to the iris plane, so it creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. I'm injecting some intracameral lidocaine and some now dispersive viscoelastic to fill the anterior chamber, using the cannula to control the eye. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea. As I'm tunneling, I just go short of the angle of the blade and then turn the cannula and eye towards me and then enter. I inject some more viscoelastic to inflate the anterior chamber and hopefully flatten the anterior capsule before I start my rhexis. I do my puncture style Capsulorhexis, pulling it down towards me, grabbing the right side of the tear, and then starting the flap. Going around circumferentially, counterclockwise, and grabbing and re-grabbing. I do feel like injecting that little dollop of viscoelastic right before I do my rhexis helps quite a bit to achieve a well-controlled rhexis. So this is the Capsulorhexis hydrodissection technique. I place a cannula out to the equator contra-incisionally, get a nice fluid wave. The bag starts to come out, decompress the bag, pointing the tip down to the right, and the lens spins nicely. Nowadays, I'm liking to get that bag up. I do think it does loosen the lens from the bag. I'm using the chopper to go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Place the chopper underneath the epinuclear ridge out to the equator, pointing the phaco tip vertically sub-incisionally, crushing the lens by bringing it together, dividing the lens, placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip, and dividing that right heminucleus in half. That is double chop and cross chop. Using some vacuum to pull that first quadrant up out of the bag, getting around it with a chopper, crushing it and dividing it using mechanical fracturing forces, and then dividing the lens piece once they're smaller enough, and then dividing the lens piece once it's small enough. Placing the chopper around the second quadrant, pulling it centrally towards the phaco tip, dividing the lens piece in half, using some vacuum to grasp the lens piece, and then crushing it with the chopper, placing the chopper around that fragment, pulling it up out of the bag, crushing it and dividing it into smaller pieces between the chopper and the phaco tip, and then emulsifying the lens piece. Very carefully turning that second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, dividing that second heminucleus in half, using successive mechanical fracturing forces, sandwiching the lens piece into smaller pieces, and then emulsifying the lens piece. Using a little bit of vacuum to just pull that last fragment up out of the bag, placing the chopper around the lens piece and crushing it between the chopper and the phaco tip and emulsifying the lens pieces. So you can see this is a fairly average lens density. It does have some thickness to it, and I'm having to use some ultrasonic energy to emulsify the lens piece. Once all the endonucleus is removed, I grasp the anterior portion of the epinucleus and it tumbles out of the bag quite nicely, protecting the posterior capsule with the chopper. It looks pretty clean, but you can see in the sub-incisional area as I'm sweeping, there is some cortical material there, and I'm sweeping around, but I'm also going on the posterior capsule side and releasing any adhesions on the posterior capsule with the INA handpiece. By releasing the adhesions on the posterior capsule side, it does ensure that it'll be more easy to remove the cortical material with the sub-incisional capsule flush technique. So I'll place the cannula through the paracentesis incision, point the tip underneath the rhexis edge in the sub-incisional space, and you can see it's able to pulse and remove that sticky, stubborn cortical material that's in the sub-incisional fornix. And that's the key. When you see that material attached to the posterior capsule, you know that when you do the sub-incisional cortical flush technique, it will cause that material to come out. And it's important to make sure that it does come out because it's there. So I inject the cohesive viscoelastic to fill the bag and I start to polish with the sweep, first on the left side and then on the right side. And this just helps sweep off the lens epithelial cells that have been loosened from the INA polishing technique. Now I'm able to remove it a little bit easier. So I'm injecting the single piece acrylic intraocular lens into the capsular bag. Go in with irrigation off, activate irrigation, disengage each haptic off the optic, go underneath the optic, tilting it and rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag and underneath the lens. Polishing underneath the rhexis again one more time. Invariably, there's some very minute lens material that's still there. Rotating the haptics horizontally, and then switching to visco mode and remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So again, this is kind of a average lens density, 1+ dense lens. You saw that there was quite a bit of sub-incisional cortical material. And the telltale sign is as I'm polishing the posterior capsule surface, if I see this wispy cortical material that's adherent to the sub-incisional posterior capsule, that means that that material propagates up into the capsular fornix because all of it's a long string that starts from anterior to posterior, like spokes of a wheel. And so if it's on the posterior side, it is definitely into the sub-incisional capsular fornix, and that's why that sub-incisional cortical flush technique is really a very helpful maneuver using that BSS cannula. You have to make sure that the tip of the cannula is definitely underneath the rhexis edge into the capsular bag. You want to turn the INA handpiece away from your maneuvers so you don't accidentally catch the capsule as you do this maneuver. So I hope this was helpful to you, and I thank you for your attention.